Dear student, the topic of this video is menopause. Learning objectives are definition, clinical features of menopause, physiological basis of menopause, and perimenopause. Menopause at the climacteric, it signals the termination of reproductive function of women. Termination of reproductive function of women. Now, cyclic reproductive function ceases. Menstruation comes to an end and childbearing is no longer possible during this time. Now, average age at onset of menopause is around 52 years. At menopause, the human ovaries become unresponsive to gonadotropins. Functions of the ovaries decline. Uterus, vagina gradually becomes atrophic. Sexual cycles disappear. Ovaries no longer secrete progesterone, 17-beta estradiol in appreciable amount, but small amount estrogen is formed by aromatization of androstenedione at peripheral tissues. Now, why the ovaries become unresponsive to GnRH? Unresponsiveness is associated with and probably caused by decline in the number of primordial follicle. At birth, we know 1 to 2 million of follicular units remain in the ovaries. At the time of puberty, some of it undergo atresia and remains around 3 to 4 lakh within the ovary. But at the time of menopause, there will be no active primordial follicle. So this massive loss of oocytes over the reproductive life from 4 lakh at puberty to virtually none at menopause is the result of rapid continuous process of atresia during reproductive life. This is the hypothalamo-pituitary gonadal axis in case of female. We know that GnRH, it stimulates the anterior pituitary to release the LH and FSH, and FSH stimulates the granulosa cells to release the estrogen. LH, it helps in the synthesis of estrogen. The released estrogen, it gives a very strong negative feedback, on the anterior pituitary and the GnRH from the hypothalamus. And another hormone that is released, the inhibin B from the granulosa cell, that also gives negative feedback on FSH. Now in menopause, I told you previously that there is lack of estrogen, lack of progesterone, lack of inhibin. So if estrogen level is less, then estrogen will be unable to give negative feedback on the pituitary and the hypothalamus. Inhibin will be, as its level is less, it will not be able to give negative feedback on the FSH. What will be the result? Secretion of FSH will be increased. So the secretion, the inhibition on the anterior pituitary by this estrogen and inhibin, it will be withdrawn. So there will be no secretion of this FSH. Plasma FSH level increases to high level. LH levels are also moderately high. Now during menopause, the anterior pituitary, so we know that ovary is not secreting adequate amount of estrogen and inhibin. What about the pituitary? Are they releasing LH and FSH? During menopause, the anterior pituitary still secretes FSH and LH in pulses, presumably after cyclic release of GnRH from the hypothalamus. Although gonadotropins, but LH, FSH are released But gonadotrophins cannot generally stimulate the post-menopausal ovary. It appears that gonadotrophins in the anterior pituitary can respond to exogenous GnRH also. Now, before the onset of menopause, few years before the actual onset of menopause, there may be a phase known as perimenopause. It usually occurs between the ages of 45 to 55 years. At that time, the menses become irregular, there will be decrease in the progesterone, estrogen and inhibin, and the FSH level is increased before an increase in LH. So what are the symptoms of menopause? When the estrogen and progesterone and inhibin, all these levels are less, ovarian follicle is absent, and atrophy of the different female reproductive systems are occurring. So what are the symptoms of it? So other than the symptoms due to the changes of the reproductive system, for example, there will be change in the vaginal pH, atrophy of the vaginal epithelium, decrease in the circulation of vagina and uterus, there will be pelvic relaxation, loss of vagal tone. These are the symptoms related to the female reproductive tract. There are some systemic symptoms as well. There will be vasomotor instability, hot flashes, night sweats, mood changes, irritability, short-term memory loss, sleep disturbances, headache, loss of libido, and most importantly, postmenopausal women, they have very high risk of cardiovascular disease, osteoporosis, Alzheimer's disease, because we know estrogen gives a very protective action on the bone density, on the cardiac activity. So lack of estrogen will generate so many systemic problems as well. Now we want to concentrate a specific very important problem here, that is the hot flashes during the postmenopausal period. What is this hot flash? Hot flashes occur 75% of menopausal women. It may continue intermittently for as long as 40 years. Its cause is unknown. It coincides with the surges of LH secretion. LH is secreted in episodic bursts at an interval of 30 to 60 minutes or more. So this is known as circular release of the LH. Now each hot flash begins with the start of such a burst. So there will be LH burst like this. So each hot flash, it begins with the start of such a burst. However, LH itself is not responsible for the symptoms. Although this hot flash, it coincides with the pulsatile increase in the LH secretion, but the LH itself is not responsible for the symptom. How do you know that? Because if the pituitary is removed, that means if there is no pituitary, so there is no LH. Even after removal of pituitary, there will be continuation of this hot flashes. Then what is the possible reason? It coincides with LH burst, but removal of anterior pituitary will not cause any defect, any change in the hot flash. So some estrogen sensitive event in the hypothalamus, it initiates both the release of LH and episode of flashing. Thank you.